We still have 2 more minutes. Okay, yeah, sorry. Okay, good morning. I'm sure you all are wondering where our grades are. They are not in my closet. They are going to get, sorry that it's taking a little longer than usual because two of the students took an exam on Friday. Can everyone hear me on the Zoom?
Yes, we hear you.
Okay, so the delay was also because of Friday exam. We couldn't release the grade before Friday. And also the other thing is, we have adjunct faculty teaching. So to, see if they needed any adjustment and all that, so took us a little longer than usual. I know you guys are all anxious about what the grade looks like. Sometime today, it will be posted. Okay? So you should be able to see it, so. Sorry for the delay again. Thank you for your patience. Any questions? No? Okay, Dr. Cullen can proceed with today's lecture on breast cancer.
Okay, we'll go ahead and get started. We have a lot to get through. It's nice to see you guys again. I was here a couple weeks ago for the hormonal agents. And today we'll be talking about breast cancer. So by the end of today's presentation, you should be able to understand the clinical presentation and classification of breast cancer, identify the main treatment strategies for breast cancer, taking into consideration tumor characteristics, explain the main adverse effects of treatments and associated management strategies, and also develop appropriate treatment plans for early stage and metastatic breast cancer patients. So a little bit of background on breast cancer. It is the most common cancer in the United States and in women. It accounts for 15.5% of all cancers in the United States. It is the second leading cause of cancer death behind lung cancer. In 2024, there were over 300,000 Americans diagnosed with breast cancer and just under 43,000 deaths. To kind of put it into perspective, approximately 13.1% of women will be diagnosed with female breast cancer at some point during their lifetime, and this is based on data from 2018 to 2021. And as you can see on the slides here, I've broken it down of the percent of cases by stage. So most breast cancers will be localized, which is going to be confined to the primary site, which would be the breast, in about 63% of patients, which is the dark green. Regional is where it's spread to the regional lymph nodes. That's in 28%. And 6% is distant breast cancer or breast cancer that is metastasized. As far as 5-year relative survival, as you can see, the localized, so just confined to the breast, 5-year relative survival is 99.6%. So for a lot of times we're catching this early, patients have really good outcomes with 5-year survival data. If it is spread to the lymph nodes, it's a little bit higher risk, and that relative survival goes down to 86.7%. And then when you get into distant or metastatic disease, that 5-year relative survival goes down significantly at 31.9%. So this is important to know that, you know, a lot of times we're catching it early, which is great, but if they do have metastatic disease, the outcomes and their chance of surviving are significantly lower. So to kind of start and talk about the pathophysiology and anatomy, majority of breast cancers are epithelial tumors or adenocarcinoma. This develops from cells lining the ducts or lobules in the breast tissue itself. So the lobules are football-like shapes in the breast, and then the ducts connect the lobules to the nipples. The lobules are the glands that produce the milk, and then the ducts are those tubes that carry the milk to the nipple. It can evade locally and spread through regional lymph nodes, bloodstream, or both. It's important, the targets that we have, the main molecular targets are estrogen and progesterone receptors, and then also our human epidermal growth factor 2 or HER2. Estrogen and progesterone receptors are hormone receptors that promote DNA replication and cell division when the appropriate hormones bind to them. Estrogen receptors express in approximately 70% of invasive breast cancers, so it's very common. As far as HER2, it is an oncogene and transmembrane receptor tyrosine kinase in the epidermal growth factor receptor family. So this is a normal gene that makes protein receptors that are involved in the growth and the division of cells in the breast. So these are going to be important when we talk about treatment because we're either going to target the hormone receptors or we're going to target HER2. As far as risk factors, there's a lot of risk factors that can put patients at risk for breast cancer. The two largest risk factors are increasing age, so older patients, as well as female sex. Males can get breast cancer. It's not as common. It's like 2,800 males in 2023 were diagnosed with breast cancer, but we do see it in males. There are hereditary or inherited genetic syndromes. For hormonal factors, this is a big one. So this is exposure to estrogen, so endogenous exposure to estrogen, early age at menarche at less than or equal to 12. So time of their first period being earlier in life, nulliparity or not having any children is a risk factor. And if they have late age at first full-term pregnancy, which is defined at greater than or equal to 30 years old. Another risk factor is late age at menopause, so greater than or equal to 55. All of these, essentially, they're just having increased exposure to estrogen over time. Exogenous hormonal factors include hormonal contraception, specifically oral contraception, and then if they are on hormonal replacement therapy in the postmenopausal setting. Obesity is a risk factor, as well as breast density, because it is difficult if someone has dense breast tissue. It's hard to screen that and see that on mammograms. And if they have had prior radiation exposure, this also puts them at increased risk. Some things that can decrease the risk, if they have increased physical activity, no alcohol, and then if they have a family history of breast cancer, this also puts them at increased risk. There are some genetic risk factors, and about 5 to 10% of patients do have identifiable genetic mutations. So we have BRCA1 and BRCA2 gene mutations, and this is nearly 85% lifetime risk. So if patients have these, there are additional screening things that we won't go into today for the purpose of this lecture, but just want you to be aware of BRCA1 and BRCA2 are not super common, but they can be found in 5 to 10% of patients. And these are, passed down through family members. And we also have the Li-Fraumeni syndrome with the TP53 mutation is also common. So screening and prevention is really important, and I've included the recommendations here from the National Comprehensive Cancer Network, or NCCN guidelines. And screening is really a main reason why breast cancer has a good overall survival, with majority of patients being, diagnosed with early stage disease, as we saw in one of the earlier slides. So if patients are 25 years or older, it is recommended to do breast awareness with a self-breast exam. In the 25 to 39-year-old age group, it's recommended to get a clinical breast exam every 1 to 3 years, whether it's with the primary care provider or the gynecologist. And then when they hit 40 years old, it's recommended to do clinical breast exam and mammogram annually. So mammogram is really your gold standard for screening and prevention. So when patients are 40 years and up, they should be getting an annual mammogram. There's some different resources for how often we should be doing the mammograms, but for purposes of this lecture, we'll stick with the NCCN recommendations for how often to get mammograms. There are agents that can be used for breast cancer prevention. This is for women with at least one risk factor for developing breast cancer. So if they are premenopausal, tamoxifen would be indicated for breast cancer prevention. Postmenopausal, we have some more options: tamoxifen, raloxifene, exemestane, and anastrozole. Specifically for tamoxifen and raloxifene, this is contraindicated if they have a prior history of a DVT, pulmonary embolism, or stroke. However, the use is pretty limited for breast cancer prevention because the side effects can be, affect their quality of life, and it has an overall small absolute difference in outcomes. But for certain patients, you can consider doing breast cancer prevention by using these endocrine therapy agents. For prophylactic surgery, this might be considered for patients at highest risk, may consider surgery to prevent breast cancer. Specifically, we might see this more in the BRCA1 and BRCA2 mutated patients, since they have such a high risk for developing breast cancer. You can do a bilateral mastectomy, which is removal of both breasts, and also do a bilateral salpingo-oophorectomy, which is removal of the ovaries and the fallopian tubes. For BRCA mutation, this prevents both breast cancer and ovarian cancer, because if they are BRCA1 and 2 positive, that puts them at increased risk for not only breast cancer, but ovarian cancer and other types of cancers as well. So how do these patients present? They can present in a multitude of ways, but the most common is either finding a lump in their breast or a lump in their armpit. They can also present with skin redness around the area, dimpling or puckering of the skin. If they have any discharge from their nipple changes, so if it's pulling inward or pulling to one side. If they have any sort of ulceration or thickening of the skin, which you can kind of think of as like an orange peel texture. But most commonly, patients might find a lump in their breast or in their armpit, or sometimes they're presenting with no symptoms at all, and it's just found on the annual mammogram. So how do we go about diagnosing patients who might have breast cancer, and kind of what does their workup look like? So at baseline, we should be getting a history and physical exam. As far as imaging, mammogram is going to be, our gold standard for screening, but we also will need this to work up a patient, potentially an ultrasound and an MRI. And then, depending on what the results of that shows, we should be doing a biopsy, because it's important to drive our treatment. We need to determine if the mass is actually breast cancer or not, and then that hormone receptor and HER2 status. We would also want to address fertility concerns, especially if you have a younger patient that may, want to pursue having a family, and then also pregnancy test. So what are the various factors that affect both prognosis and our treatment? So the presence or the absence of the tumor growth receptors. So these are our hormone receptors, which is going to be HR, and we have the estrogen receptor and progesterone receptor, so ER and PR. And we also have HER2 as well. We're also going to be looking at stage, whether they're early stage or advanced stage with metastatic disease, their tumor differentiation, and the proliferation index, which is good. It's gone through the Ki-67, just looking at how rapidly those cells are dividing. So in terms of what types of breast cancer are there, there's 4 main buckets of breast cancer. So we have HR positive, HER2 negative. We have HR positive, HER2 positive, HR negative, HER2 positive, and then we also have triple negative, which is HR negative and HER2 negative. In terms of prognosis, patients with triple negative breast cancer have the worst prognosis because we don't have anything. We can't target the hormone receptor. We also can't target HER2 as well. If they are HER2 positive, this is a faster growing cancer, but we do have anti-HER2 treatments, which has helped the outcomes if a patient does have HER2 positive. So in terms of level of invasiveness for breast cancer, we have lobular carcinoma in situ, which is benign, so this is not considered breast cancer. And then we have ductal carcinoma in situ as well, which is non-invasive. And then where we start to get into invasive breast cancer is stage 1 through 3. And then stage 4 is going to be metastatic breast cancer, where it is spread to other organs outside of the breast. Okay, I have the first knowledge check, and I will send you these questions after the lecture, as well as some points to kind of highlight and focus on for the exam. So first we have MK is a 55-year-old female with a past medical history of hypertension, asthma, and depression. How often should she have a screening mammogram for breast cancer according to the NCCN guidelines? A, every 6 months, B, every 12 months, C, every 2 years, or D, every 5 years. Yeah, correct. So B, every 12 months, is correct. So she is over 40 years old, so we would recommend an annual mammogram per the NCCN guidelines. For our next question, so same patient, MK, 55-year-old female, past medical history of hypertension, asthma, and depression. Her menarche was at age 11 and menopause at age 53. She is G1P1 and her first child was at age 33. She was also prescribed oral contraceptives for 8 years. What are her risk factors for breast cancer? Yeah, so having her first child after 30 is a risk factor. Correct, oral contraceptive, so that exogenous exposure to estrogen. What is it? Early menopause. Yes, yeah, so the age of her first period was at 11, so less than or equal to 12. Her menopause was at 53, so that is not a risk factor because she was less than 55 years old. Any questions on any of this before we kind of move into early stage breast cancer? Great, so now we will kind of transition to early stage breast cancer and what we do for treatment. So there's 3 big buckets for treatment modalities. So we have surgery, which can either be breast conserving surgery with a lumpectomy, so just removing the lump, or a mastectomy. They'll also most likely undergo radiation therapy, and this will be in the adjuvant setting for our early stage breast cancer. And then we have systemic therapy as well, which will include endocrine therapy, chemotherapy, and HER2-directed therapy. So the endocrine therapy is going to be those agents that we talked about in the hormonal agents lecture for your past exam. So this is just kind of orient you to the breast. I know we talked about this a little bit, but DCIS is where you have abnormal cells that are lining the ducts, which are responsible for that milk secretion. but the abnormality has not spread to those other tissues. So as you can see here, it's all within the duct, so that blue is all within the duct. It hasn't spread outside. Where you get invasive is when it has left the duct and spread to other parts of the breast tissue. So for DCIS or stage 0, this is that non-invasive. The goal is to prevent progression to invasive disease. So normally for these patients, if they are found to have DCIS, definitive treatment is breast conserving surgery and then potentially followed by breast radiation therapy. Alternative is if they do a total mastectomy with or without a sentinel lymph node biopsy, if it's found to be invasive during surgery. But typically, if we're doing breast conserving surgery, then they will need radiation. And then they will also potentially undergo risk reduction therapy if they are hormone receptor positive. So they will get 5 years of endocrine therapy, tamoxifen if they are premenopausal, or tamoxifen or an aromatase inhibitor if they are postmenopausal. HER2 status in DCIS is of unknown significance, so we're really focusing on that HR positive. And then they should also have follow-up with a physical exam and mammogram every 6 to 12 months for surveillance. This is just kind of to show you what a biopsy actually looks like. So this is a sentinel lymph node biopsy. They insert the dye into the tumor, they look and see at the nodes as well with the probe, and then they will remove those lymph nodes if they show up based on the dye. So for staging, this is simplified from the TNM system. Just looking at the tumor, the nodal involvement, and then if they have distant metastases or not. So for stage 1, this is going to be invasive. The cells are no longer confined to that duct. The tumor may be up to 2 centimeters in size. They might have micrometastases, but no larger than 2 millimeters in 1 to 3 lymph nodes. For stage 2, the tumor is bigger. So this is going to be a tumor 2 to 5 centimeters with or without larger metastases greater than 2 millimeters to those nodes. Or if the tumor is greater than 5 centimeters without any nodal involvement. Stage 3 includes spread to 4 or more nodes, if they have spread to the chest wall or skin. And then stage 4 is going to be metastatic, where it's spread to other organs. So as you can see in this picture, the tumor is getting bigger and there's more nodal involvement as well. So to kind of break down how we treat patients with early stage breast cancer. So the figure will start on the left with HR positive. So then this is going to be divided between if they are HER2 negative or HER2 positive. So if they are HR positive, HER2 negative, they will get endocrine therapy because they're HR positive, plus or minus chemotherapy. If they are HR positive and HER2 positive, then they'll get endocrine therapy plus chemotherapy, and then because they're HER2 positive, they will get HER2 directed therapy. Now, on the other side, looking at the HR negative, if they are HR negative, HER2 negative, they will get chemotherapy because we don't have any receptors to target. So that's really our only option for those patients. Go ahead. Do you have a question? No, okay. If they're HR negative, HER2 positive, we still have the chemotherapy, and because they're HER2 positive, they will get HER2 directed therapy. So for stage 1 and 2, this is invasive and operable. The treatment goal for this is going to be cure. These patients will undergo surgery, so they can either get a radical mastectomy, so removal of both breasts, or a breast conserving surgery with a lumpectomy. The outcomes are the same for both, so it's just dependent on patient preference and what they decide with the surgeon, what is best for them. In terms of adjuvant systemic therapy, so this is going to be to prevent recurrence and eradicate any undiscovered distant metastases that might be there. And I've included this table here, kind of going back to the previous slide. If they are HR positive, HER2 negative, they'll get endocrine therapy plus or minus chemotherapy. If they're HR positive, HER2 positive, then we add on the anti-HER2 antibodies. If they are triple negative or HER2 negative, they'll undergo chemotherapy. HR negative, HER2 positive, chemo with that anti-HER2 antibody. So in some cases, we do consider preoperative systemic therapy, and this is termed neoadjuvant chemotherapy. So the known benefits for this, it can sometimes facilitate breast conservation for patients. If a tumor is found to be inoperable in the beginning, if we give upfront therapy prior to surgery, it might shrink it and make it operable. The response, if they have a response to neoadjuvant treatment, that helps provide prognosis information. So they may adjust systemic therapy after surgery based on response or a lack of response. Does allow time for genetic testing if there's any mutations that we can target, and allows time to plan breast reconstruction if mastectomy is planned. So who are potential candidates for neoadjuvant systemic therapy? Candidates might include many patients with inoperable breast cancer, if they are currently operable, but if they have more extensive disease, so a larger tumor or a lot of lymph node involvement, or if they have a really large tumor and they desire breast conservation, or patients in whom surgery might be delayed. Patients that are not candidates, if they have a poorly delineated extent of the tumor is not palpable or clinically evaluable, or if they have extensive in situ disease, when extent of invasive carcinomas are not well defined. Typically, we will see this in our HER2 positive and triple negative patients. If they're hormone receptor positive, HER2 negative, we don't do it as commonly, but it's still an option, depending on if they're candidates or not. So there are similar outcomes when chemotherapy is given before or after surgery. The neoadjuvant and adjuvant regimens are very similar in terms of what we would give. If the patient is HER2 positive, then they should receive preoperative trastuzumab, which is an anti-HER2 antibody. And really our goal of preoperative systemic therapy is to have them have a complete pathologic response. So when they go in for surgery, they're not able to find any residual disease. That treatment that we gave up front was able to eradicate the disease. If they get neoadjuvant therapy and then they have surgery and there's still residual disease there, that likely means that we're going to change treatment in the adjuvant setting because the neoadjuvant treatment was not as effective as we would have liked. Okay. Just going back to this is really the foundation of what a big takeaway point is in terms of what receptors they have and what treatment that we will give. So now looking at our HR positive, HER2 negative patients a little bit more closely. So our treatment is going to depend on the tumor size. So if the tumor is small and up to 0.5 centimeters, then we're going to consider adjuvant endocrine therapy. If they have a larger tumor, so greater than 0.5 centimeters or smaller with up to 3 involved lymph nodes, we want to consider genetic testing, and this genetic testing has been validated to determine which patients benefit from chemotherapy. So if we can avoid chemotherapy, that's great because there are risks associated with giving chemotherapy, but for some patients it is indicated. So if they have a low recurrence score, then chemotherapy would not be indicated and you would just do adjuvant endocrine therapy. If they have a high recurrence score or a test not done, then you would do adjuvant chemotherapy followed by endocrine therapy. No matter what, they're going to get endocrine therapy. It's just we're deciding if they should get chemotherapy or not. If they have more than 4 involved lymph nodes, then they are definitely a candidate for adjuvant chemotherapy. We don't need to do any further genetic testing, followed by endocrine therapy, and then also plus or minus a CDK4/6 inhibitor, which is abemaciclib or ribociclib. We'll talk about that more in the metastatic setting, but if they have, higher risk disease up front, then we're going to add additional therapies. If a patient is premenopausal, this is where we should add ovarian suppression and ablation, might be part of endocrine therapy if we're going to give it with an aromatase inhibitor. If they're just receiving tamoxifen, then we don't have to give ovarian suppression for those patients. So what is this genetic testing that I was talking about? One that we typically use is called Oncotype DX. So this is a breast recurrence score, and it analyzes the activity of 21 genes. So this is going to help determine our risk of recurrence in HR positive, HER2 negative patients. So if their recurrence score is less than 25, they have a low risk of recurrence with endocrine therapy alone. So patient population, we can just do endocrine therapy. If their recurrence score is greater than or equal to 26, this indicates that they have a high risk of recurrence with endocrine therapy alone. So chemotherapy is recommended after surgery, followed by endocrine therapy. As you can see here for this example, the recurrence score is 32. So it shows you the distant recurrence risk at 9 years with an aromatase inhibitor or tamoxifen alone. So just doing endocrine therapy by itself, their chance of having recurrence of the breast cancer at 9 years is 20%. So then on the right, they tell you the average absolute chemotherapy benefit. If their score is 26 or higher, is greater than 15%. So in this example, chemotherapy would be indicated for this patient because the benefit outweighs the risk of receiving chemo. So what options do we have for chemotherapy? So if patients are HER2 negative, we can do AC, which is doxorubicin plus cyclophosphamide, followed by paclitaxel, or TC, which is docetaxel plus cyclophosphamide. If they are stage 2 to 3 triple negative breast cancer, we can give preoperative or neoadjuvant pembrolizumab plus carboplatin, so an immune checkpoint inhibitor with chemotherapy, plus paclitaxel, and then they would also receive pembrolizumab plus doxorubicin plus cyclophosphamide, and then in the adjuvant setting, so after surgery, they would go on to receive pembrolizumab. For HER2 positive, some options include paclitaxel plus trastuzumab, or TCH, which is docetaxel, carboplatin, trastuzumab, or TCHP, which is docetaxel, carboplatin, trastuzumab, and pertuzumab. Trastuzumab and pertuzumab are anti-HER2 antibodies that we use to target the HER2 positive patients. So to just kind of give you an idea of what these chemotherapy regimens might look like. So we have dose dense AC. You might be wondering what does dose dense mean? This is just meaning we're giving them closer together. We're giving them every 2 weeks instead of every 3 weeks. There's been a lot of research and data to support giving them closer together provides better outcomes for patients. So they will receive doxorubicin and cyclophosphamide on day 1 every 14 days for 4 cycles, followed by dose dense paclitaxel, which is paclitaxel 175 milligrams per meter squared on day 1 every 14 days for 4 cycles. Another common regimen that we use is dose dense AC followed by weekly paclitaxel. So you're giving the AC component, the doxorubicin and cyclophosphamide at the same frequency. And then instead of doing every 2 weeks for the paclitaxel, they'll just get weekly paclitaxel for 12 weeks. The other common regimen that we use is TC, which is docetaxel and cyclophosphamide, and this is every 3 weeks. Does anybody know why we might want to avoid a anthracycline like doxorubicin? Is there anything you can think of in terms of like past medical history? Or we would want to right. So if a patient already has cardiotoxicity at baseline, we're probably not going to do dose dense AC. So for those patients, we would want to do TC because there's no cardiotoxicity risk with TC. Generally, if patients have higher risk and a lot of lymph node involvement, we will want to try and give them the dose dense AC, either with dose dense paclitaxel or weekly paclitaxel. If they don't have as much nodal involvement, then you might do TC. TC may also be indicated for patients that are older and maybe their performance status isn't as high as well. So for anthracycline adverse effects, we have nausea and vomiting. So that's a really big one. They're considered highly emetogenic. Neutropenia is also really common, so if a patient is getting dose dense AC, then they should get growth factor. Alopecia or losing their hair is really common with anthracyclines, mucositis or mouth sores, fatigue, urine, sweat, and tears discoloration, and they may be pink or red. So it can potentially stain contacts as well. So advising patients to take out their contacts and making them aware that their urine, sweat, and tears might be discolored because, as you can imagine, if you're not aware of that and that happens, it could be potentially scary for a patient. So making sure that, you know, whether we're providing education on that or the nurses, making them aware of that. Rare, so cardiomyopathy is rare, but it can cause decreased left ventricular fraction or heart failure. And then another one that is rare, but can happen is secondary malignancies. So they might be at risk for leukemia, in a few years if they receive an anthracycline. I don't know why this did not show. There we go. Okay. So for taxane adverse effects, we have myelosuppression, edema or fluid retention, nausea, nail changes, peripheral neuropathy. So this is very common with our taxane agents. You can have peripheral neuropathy, that tingling numbness in their hands and feet. Hypersensitivity reactions are pretty common with our taxane agents. So making sure, you know, patients are aware of the potential risk for infusion reaction, and then making sure that we are giving the correct pre-medications prior to them receiving a taxane, which is normally a steroid. And then they can also have arthralgias and myalgias, muscle joint pain, and then alopecia as well. For adjuvant endocrine therapy, this is recommended for all patients with ER/PR positive invasive breast cancer. They should receive this for a minimum of 5 years. In some cases, you might go up to 10 years, depending on their risk. If they are premenopausal at diagnosis, they should either receive tamoxifen by itself or an aromatase inhibitor with ovarian suppression. As we talked about previously, aromatase inhibitors include anastrozole, letrozole, and exemestane. For ovarian suppression, we have goserelin, leuprolide, or an oophorectomy. If they are postmenopausal at diagnosis, then they can just get an aromatase inhibitor by itself. You can either start this upfront or they can do it after tamoxifen. So for premenopausal endocrine therapy, again, this is either going to be tamoxifen or an aromatase inhibitor with ovarian suppression. This reduces annual odds of recurrence by 39% and can reduce the annual odds of death by 31%. If they are going to receive chemotherapy and endocrine therapy, they should receive chemotherapy first, followed by endocrine therapy. For tamoxifen, 10 years is recommended over 5 years. As we talked about previously, there are drug-drug interactions due to CYP2D6 with tamoxifen. So making sure that we are screening the medication list for review to make sure there's no significant interactions. Tamoxifen does increase the risk for endometrial uterine cancers. So, you know, providing education on that. It is a low risk, but it still does put them at potential increased risk. And then also thromboembolic events. Main side effects, which I know we talked about this previously in our last lecture, but hot flashes are very common. For aromatase inhibitors, this can be given for 5 years with ovarian ablation or suppression. So this is going to be our premenopausal patients. For our postmenopausal patients, that would be indicated for endocrine therapy. If they are postmenopausal at diagnosis, they should receive an aromatase inhibitor, so anastrozole, letrozole, or exemestane, initially or after tamoxifen. So kind of comparing an aromatase inhibitor versus tamoxifen, there are improvements with an aromatase inhibitor over tamoxifen. So it has better disease-free survival and a lower rate of recurrence in the same breast, opposite breast, or distant metastases. Aromatase inhibitor adverse effects include hot flashes, bone loss, and arthritis and myalgias. If a patient, for whatever reason, is not able to tolerate an aromatase inhibitor, then you could certainly do tamoxifen, but we should be trying to do an aromatase inhibitor upfront for patients that are postmenopausal. Now going back to this slide, we're going to focus on HR positive, HER2 positive patients. So for HR positive, HER2 positive, this is when we're going to bring in our HER2 antibodies. So it's again dependent on tumor size and nodal involvement will really drive what we are giving in the adjuvant setting. So if the tumor size is up to 0.5 centimeters, they don't have any nodal involvement, you can consider adjuvant endocrine therapy plus or minus chemotherapy with trastuzumab. If the tumor size is up to 0.5 centimeters and they do have node involvement, adjuvant endocrine therapy is recommended, or you can give adjuvant endocrine therapy plus chemotherapy with trastuzumab. This is also indicated for tumors that are 0.6 to 1 centimeters. If the tumor is greater than 1 centimeters, is recommended to do adjuvant endocrine therapy plus chemo with trastuzumab. If they have a larger tumor and have more extensive nodal involvement, this is when you would want to do adjuvant endocrine therapy plus chemotherapy with trastuzumab and pertuzumab. So 2 of the anti-HER2 antibodies, or you don't have to do pertuzumab, you can just do trastuzumab by itself, but it really is preferred if they have more extensive nodal involvement. The outcomes are better with chemotherapy with trastuzumab and pertuzumab. There are more side effects that are associated with trastuzumab and pertuzumab versus just doing trastuzumab on its own. And as you go down the table, the increasing strength of recommendation, so there's more and more data to support that that is what we should be doing. Whereas like at the top, it says consider chemotherapy. There's not as much data to support that, so likely get away with just endocrine therapy in that setting. Now for HR negative, HER2 positive, so kind of similar in terms of tumor size and node involvement. If they don't have nodal involvement and their tumor size is up to 0.5 centimeters, you would consider adjuvant chemotherapy with trastuzumab. So because they are hormone receptor negative, we don't need any adjuvant endocrine therapy for these patients. If they have nodal involvement, again, considering adjuvant chemotherapy with trastuzumab. If their tumor size is greater than 1 centimeter, doing adjuvant chemotherapy with trastuzumab. If they have more extensive nodal involvement and a larger tumor, then this is where we want to give chemotherapy with trastuzumab and pertuzumab. Another option is just doing trastuzumab by itself, but it is recommended to do both. So now to talk through some of the common chemotherapy regimens. For this patient population, you can do paclitaxel plus trastuzumab. So paclitaxel weekly for 12 weeks with trastuzumab, with the first dose of paclitaxel followed by trastuzumab weekly to complete 1 year of treatment. And important to note with trastuzumab, you will get a loading dose. If you're doing weekly, it's 4 mg per kg upfront and then 2 mg per kg thereafter. Alternatively, you can do move to every 3 weeks after completion of paclitaxel, so you don't have to have the patient come back to the infusion center as often. And that would be 6 mg per kg every 3 weeks. The other one that you can give in this setting is TCHP. So this is docetaxel plus carboplatin. The carboplatin is dosed based on the AUC or area under the curve, and this takes into account creatinine clearance plus 25 times the area of under the curve, whatever you're targeting. Normally it is 5 or 6. This is given in combination with trastuzumab and pertuzumab every 3 weeks for 6 cycles. And then they would continue trastuzumab, pertuzumab for 1 year. So normally you get chemotherapy for 6 cycles, finish the chemotherapy component, and then they will continue on the anti-HER2 antibodies for 1 year. So what side effects can we expect from HER2 directed therapy? Cardiotoxicity is somewhat common with these. It is usually reversible. So if you hold or stop the HER2 directed therapy, then their cardiac function should return to baseline. However, we do need to monitor an echo during and after treatment to make sure that their ejection fraction is staying the same. There's really nice guidance in the package inserts for trastuzumab and pertuzumab. If the patient's ejection fraction does drop, they provide recommendations on, whether you need to hold, dose reduce, and normally if they have some sort of ejection fraction drop, we have them seen by cardiology for further recommendations. Another common is hypersensitivity reaction. So they will have a longer infusion time during their first dose. And then diarrhea is common, but this is only with the pertuzumab component. If they're just receiving trastuzumab by itself, they typically won't have any diarrhea. They might have diarrhea from chemotherapy, but when they're just on trastuzumab alone in the adjuvant setting, they won't have diarrhea. But for pertuzumab, it certainly causes diarrhea. Now, looking at our last subset, HR negative, HER2 negative, which is triple negative or TNBC. So really the only options we have here are chemotherapy for these patients. If they have a really small tumor, up to 0.5 centimeters and no nodal involvement, then we wouldn't give them any chemotherapy in the adjuvant setting after their surgery. However, if they do have nodal involvement, then we can consider adjuvant chemotherapy. And then if they have a larger tumor, 0.6 to 1 centimeter or greater than 1 centimeter, then we should be giving adjuvant chemotherapy for these patients. Again, the strength of the recommendation kind of increases as you go down the table, because there's more risk for recurrence for those patients. So the chemotherapy benefit will outweigh the risk. So general principles of adjuvant therapy, kind of just to kind of tie it all up. If they are hormone receptor or HR positive, these patients should be receiving endocrine therapy plus or minus chemotherapy based on their tumor size and nodal involvement. If they are HER2 positive, we should be using our anti-HER2 antibody or antibodies, depending again on that tumor size and nodal involvement with chemotherapy. For triple negative breast cancer patients, we only have chemotherapy by itself. And treatment intensity increases with the extent of the disease, so size of the tumor and the extent of the lymph node involvement. The most common chemotherapy regimens that we use involve an anthracycline, cyclophosphamide, and also a taxane. So those are kind of going to be our backbones of treatment. So for locally recurrent disease, so if a patient had early stage breast cancer previously, and they, didn't have disease for, let's say, 5 years, and now they have recurrent disease in that same breast, but it hasn't spread anywhere else. Initial treatment is going to be mastectomy alone, or they can do breast conservation surgery with radiation. Recommendation for recurrence for the mastectomy alone or mastectomy plus radiation. They should have surgical resection plus radiation to their chest wall and supraclavicular area. Then that systemic therapy is going to be chemotherapy plus or minus endocrine therapy. If they undergo breast conserving surgery plus radiation as part of their initial treatment, the recommendation for recurrence is mastectomy and axillary dissection, followed by systemic therapy with chemotherapy plus or minus endocrine therapy. So for another knowledge check, and I promise we'll take a break here soon. DS is a 65-year-old female diagnosed with early stage breast cancer, found to have a 0.8 centimeter tumor and 1 positive lymph node during breast conservation surgery. What additional data would you like to know before making a decision regarding systemic therapy? Yeah, correct. So HR and HER2 status is going to drive our treatment, right? We have the tumor size and we know the lymph node involvement, but what are we going to give if we don't know if they are HR positive or HER2 positive? Other things, what other comorbidities do they have? Because that will indicate what chemotherapy you may or may not be able to give, and then also her current medication list. So let's say this patient is HR positive, HER2 negative, and her Oncotype DX, so that genetic testing was 32. What would you recommend based on that? Yes. Correct. So if it's greater than 26, if their oncotype is, then it would be indicated for chemotherapy followed by endocrine therapy. Great. And then our last one, before we will take a break and then move into metastatic breast cancer treatment. So this is our HR positive, HER2 negative, kind of just going back to that case to reemphasize that point, the low recurrence score, adjuvant endocrine therapy, high recurrence score, you would get chemotherapy. So for that patient, oncotype was 32, so they would be indicated to get adjuvant chemotherapy followed by endocrine therapy, like you guys said. That's perfect. All right. Any questions before we take a 10-minute break and then we'll go into metastatic breast cancer treatment? Y salió temprano.
No sé, me llegó el documento.
¿Cuál? Okay, let's go ahead and get restarted, guys. Okay. Let's go ahead and get restarted. If you guys can pause discussion. Thank you. So now we will focus, instead of early stage breast cancer, we'll move to metastatic breast cancer. So metastatic disease, or stage 4, is when the breast cancer has spread to other organs. Commonly, this is going to be the bone, lung, liver, lymph nodes, chest wall, or brain. In most cases, they have the initial diagnosis in early stage, treated with curative intent, and then a metastatic recurrence occurs. So treatment goals of metastatic are going to be different than our early stage breast cancer patients. So really our goals of treatment are to prolong their life, control tumor burden, reduce symptoms and complications, and also probably one of the biggest ones is maintain their quality of life and function. There's variability in the amount and duration of response to therapy. If they have metastatic disease on initial diagnosis, the initial therapy is systemic therapy. So we're not going to do surgery or radiation for these patients up front because it's already spread outside of the breast tissue. So there's no better outcomes in, removing that breast tumor if it's already spread to other places. So kind of stratifying the treatment options for metastatic disease. It will depend on if they have bone mets present or absent. And then again, we're pulling back in that HR receptor and HER2 status. Endocrine therapy is preferred over chemotherapy if they are HR positive. If they have visceral crises or if they have organ dysfunction due to their tumor burden, then we would start upfront with chemotherapy regardless of what subtype that they have. Kind of going through our treatment algorithm, depending again on what subtype they have. So if they are HR positive, HER2 negative, then they will receive endocrine therapy. If they are HR positive and HER2 positive, we can either do chemotherapy plus that HER2 directed therapy, or we can do endocrine therapy plus or minus HER2 directed therapy. If they are HR negative, HER2 positive, they will get chemotherapy plus that HER2 directed therapy. And if they are triple negative or HR negative, HER2 negative, then again, the only option we have for these patients is chemotherapy. So first line endocrine therapy for metastatic, for those that are HR positive, HER2 negative. Preferred first line is going to be an aromatase inhibitor, so an anastrozole, letrozole, or exemestane, plus our cyclin-dependent kinase or CDK4/6 inhibitor. And these work on the cell cycle, which I'll explain in the next slide. And this is indicated if they developed metastatic disease, not on an aromatase inhibitor. However, if they develop metastatic disease on an aromatase inhibitor, or if they had early disease relapse within 12 months of adjuvant endocrine therapy, so let's say they had early stage breast cancer, were on anastrozole for 5 years, and it's 6 months later after they just completed that endocrine therapy, then you would want to change the endocrine therapy to be fulvestrant instead of another aromatase inhibitor. And again, you would add that CDK4/6 inhibitor as well. So we have 3 CDK4/6 inhibitors that are currently approved. We have abemaciclib, palbociclib, and ribociclib. So how these work is they block retinoblastoma tumor suppression protein phosphorylation and prevent progression through the cell cycle, which ultimately results in cell cycle arrest at the G1 phase. And as you can see in this picture, they are working on the CDK4/6 inhibitor. So they're inhibiting this, which the downstream effects is you are pausing the cell cycle proliferation from the G1 to the S phase. So you're stopping the cell cycle essentially by adding these agents. So I mentioned that there are 3 CDK4/6 inhibitors. So how do we choose which one for what patients? And this is gonna be dependent on two things. One is gonna be side effects, and then also, in clinical practice, the ones that have the best data are ribociclib and abemaciclib. So they have overall survival advantage compared to palbociclib on follow-up studies did not have, the best overall survival benefit. So typically, we're using abemaciclib and ribociclib, in practice now. But there are all three options, and if a patient can't tolerate abema or ribociclib, then we might do palbociclib in those patients. A common side effect across the board is neutropenia or decrease in their white blood cell count, specifically the neutrophil count. And we usually see this more with palbo and ribociclib, not as frequently with abemaciclib, but it can happen, it's kind of a class side effect. Another class side effect is interstitial lung disease. It's very rare, but it can occur, so making sure patients are aware of this risk and, reporting any dry, lasting cough, any shortness of breath, then we want them to let us know. As far as other side effects that are unique to ribociclib, we see LFT increases. There is a chance for severe rash or cutaneous toxicity. So making patients aware of, making sure they're checking their skin daily. If they notice any changes, then they should be calling the clinic. Nausea, vomiting can happen with ribociclib. And then the big one that kind of differentiates ribociclib from both abemaciclib and palbociclib is QTC prolongation. So for ribociclib, we have to check an EKG at baseline and then 2 weeks into therapy as well. So if you have a patient that has a prolonged QTC at baseline, or if they're on another medication that can prolong the QTC, maybe you choose abemaciclib versus ribociclib for that patient. For abemaciclib, the big differentiation is diarrhea. So diarrhea occurs in like 90% of patients that take abemaciclib, so it's pretty significant. It can be a big quality of life difference for patients. So, educating on diarrhea prophylaxis and also treatment with loperamide or Imodium is important. You can also have abdominal pain. The reason why abemaciclib has more diarrhea compared to ribociclib and palbociclib is because it has a stronger inhibition of the CDK4 in particular. They all inhibit CDK4/6, but abema has a little bit stronger potency for the CDK4, which is why we have more diarrhea associated with abemaciclib. As far as administration, so administration is a little bit different as well. For palbociclib, they take 1 tablet, 125 milligrams daily for 21 days, and then they have 7 days off. And this is in a 28-day cycle. So they'll take it consistently every single day for 3 weeks, and then they have a 7-day off break, and then they will resume it after those 7 days off. And this is really due to the neutropenia.
So indefinitely or for a time period?
Yeah, so in the metastatic setting, this is gonna be until their disease progresses. So the treatment is no longer working, or if they have like unacceptable side effects. But once they have metastatic disease, we're doing treatment until they either can't tolerate treatment or if we've run out of treatment options. So it's really lifelong treatment if they're diagnosed with metastatic disease. And all three of them are 3A4 substrates, so looking out for interactions from that standpoint. Ribociclib is also on that 28-day cycle, so they'll take 600 milligrams daily for 21 days, and again have that 7-day off, and that is due to the neutropenia. They kind of need that break to let their counts recover and then restart their next cycle. For abemaciclib, this is the only one that doesn't have a break, and they also have to take it twice a day. So if you have someone that's, not good at taking their medication or is forgetful or has a really busy life, then maybe doing one that's once a day versus twice a day might be better from that standpoint. And all of these also can potentially falsely elevate their creatinine or kidney function. So that is something that we're monitoring blood work frequently while they're on these agents. So just something to be mindful of.
So for these treatment, do you give GCS or for the neutropenia or just monitor?
Typically, we just monitor. It's not indicated to give like GCSF for these patients, typically with that 7 days off, that will help them recover. If they continue to have neutropenia, then we would lower the dose before we would add any type of growth factor. But usually we're not giving any type of growth factor, we're just adjusting the dose. You can also adjust like the cycle, give them a little bit of a longer break as well, but typically we would do dose reductions first. Okay, so that was talking about first line endocrine therapy for metastatic HR positive, HER2 negative. Now, what do we do if they progress on first line treatment? There's a lot of different options. First, we have everolimus and exemestane. Everolimus is an mTOR inhibitor, but there's overactivation of the EGFR pathway in breast cancer. So we're doing that in combination with exemestane or an aromatase inhibitor. Big side effect for everolimus is mouse sores. So we actually give them prophylactic dexamethasone swish and spit solution to prevent mouse sores if they're going to be on this treatment. There's been a lot of advances in breast cancer over the last few years. So now there are mutations on the tumor themselves. So not a mutation that can be passed down from family members, but a mutation that the breast cancer and the tumor itself harbors. So commonly we see PIK3CA mutations in about 40% of patients with breast cancer. So we have a couple of agents that target PIK3CA, alpelisib, and capivasertib. And these are used in combination with fulvestrant. Capivasertib also targets AKT1 and PTEN mutations as well. So there's more patients that we can treat. The alpelisib and capivasertib, because of their mechanism targeting that PIK3CA, hyperglycemia is a really big side effect. A lot of patients have to get started on metformin, even if they don't have diabetes at baseline. And diarrhea is common with both as well. Another option we have in the second and subsequent line setting is elacestrant, but they must have an ESR1 mutation for this. So similar to fulvestrant, fulvestrant is that IM injection, but elacestrant is an oral pill that targets ESR1. So if they don't have ESR1, then you would not give elacestrant. Okay, systemic therapy for metastatic HR negative, HER2 positive patients. So again, because they are HER2 positive, we're going back to those HER2 directed therapies. Preferred regimen is trastuzumab plus pertuzumab plus docetaxel, or you can swap out the docetaxel for paclitaxel, but it should have a taxane. Alternatively, you can do added trastuzumab and tansine as well, which is an antibody drug conjugate with the trastuzumab with chemotherapy linked to it. So if they are HR positive, HER2 positive metastatic breast cancer, we have a couple of different options. You can do endocrine therapy alone, which is not super common, or we either do endocrine therapy or chemotherapy with HER2 targeted therapy. Depending on the performance status of the patient, how well they are doing and what they're presenting with in terms of symptoms. The chemotherapy with HER2 targeted therapy is the most toxic. So if they are presenting with a lot of symptoms already, maybe do endocrine therapy with HER2 targeted therapy. So it's kind of risk versus benefit in terms of what these patients might receive. As far as chemotherapy for metastatic disease, so we should be giving sequential monotherapy over our combination regimen. So as we talked about in the early stage adjuvant, a lot of those are combination regimens. We're not just giving one single agent chemotherapy, but because patients are going to be on this treatment, for the rest of their lives, as long as they can tolerate it, we should be giving it single agent monotherapy because it's less toxic. They have a better quality of life. And then we usually have to do less dose reductions as well. Some agents that we can use for metastatic disease include taxane, so paclitaxel, anthracyclines, doxorubicin. We have traditional and liposomal. If we are going to do doxorubicin in the metastatic setting, typically liposomal is preferred because it has a little bit of a better tolerability compared to traditional doxorubicin. You can also use antimetabolites, so capecitabine and gemcitabine, and then microtubule inhibitors, eribulin and vinorelbine also have good data in breast cancer. So one kind of niche drug from this previous list, capecitabine, is the only one that is oral. So a lot of times we might use this first once a patient has progressed through endocrine therapy. We might go to capecitabine first because it is the oral option. So patients don't have to come into infusion center to get treatment. They've also seen us in clinic, but it is an oral prodrug of 5-FU. Typically is administered twice a day for 2 weeks on, followed by 1 week off. So normally they'll have a 21-day cycle, take it for 14 days on, and then have 7 days off. As far as side effects, the biggest side effect is hand-foot syndrome. So making sure, they are aware of potential for hand-foot syndrome, making sure they're moisturizing their hands and feet every single day. And I only tell them at least twice a day, especially, once they're getting out of the shower, keep their body moisturized is one of the best ways to prevent hand-foot syndrome. You can also use urea cream. It's a really good moisturizer. If they start to develop hand-foot syndrome, we can do a higher strength urea cream that they can get at the pharmacy, or we might have to hold the capecitabine or reduce the dose. But it is fairly common and typically is not a side effect that we will see up front when patients get started, but it's kind of like cumulative. After they receive a few cycles, they might have hand-foot syndrome. Diarrhea is common as well, so they should take it with food to reduce diarrhea, and then also mucositis. We don't do anything prophylactically for mucositis or mouth sores with capecitabine, but just making sure patients are aware, using a gentle toothbrush. If they start to notice any pain while they're eating, to let us know. Fatigue is common. One good thing about capecitabine, it does have a pretty low risk for myelosuppression. So typically we're not dropping their counts, and nausea is pretty minimal compared to some of our other chemotherapy agents. So once we find the right dose for patients, it's typically one of the more better tolerated chemotherapy agents that we have. So for patients that have a BRCA1 or 2 mutation in the metastatic setting, about 5% of all breast cancer carries this mutation. So we have PARP inhibitors that are indicated for patients that have a BRCA1 or 2 mutation. We have olaparib and talazoparib. Olaparib, we should avoid strong CYP3A4 inhibitors. For talazoparib, avoid strong PGP inhibitors. Adverse effects from these agents: nausea, anemia, fatigue, and constipation. I would say nausea and anemia are the two biggest ones that we see. If they have a BRCA1 or 2 mutation, platinum agents, we will see a better response with these when compared with taxanes like paclitaxel or docetaxel. So if they have a BRCA1 or 2 mutation metastatic and moving to chemotherapy, we would consider cisplatin or carboplatin upfront. So other targeted agents, we talked about some of these already. Alpelisib and capivasertib target the PI3KCA mutation. Inavolisib also targets PI3KCA. It was just FDA approved a couple months ago, so just included it here, kind of for completeness sake, but we're seeing more and more targeted agents being approved based on mutations. Elacestrant targets that ESR1. And all three of the ones that have the asterisk, that's going to be an HR positive, HER2 negative only, because they're used in combination with endocrine therapy. If they are MSI high or DMMR, so microsatellite instability high or mismatch repair deficient, we have typically there's dostarlimab or pembrolizumab. Usually we're using pembrolizumab in this case. If they have an NTRK mutation, we have entrectinib, larotrectinib. And if they have a RET mutation to target selpercatinib. The NTRK and RET are incredibly rare for breast cancer, so it's not something we typically see, but if we find out that they do have this target, we can use these agents. So now just to briefly touch on male breast cancer considerations. So for preoperative or adjuvant systemic therapy, Chemotherapy plus or minus HER2 targeted therapy is the same as it would be for our female patient population. Where we see a little bit of a difference is our endocrine therapy options. So a male breast cancer patient can receive tamoxifen in the adjuvant setting for 5 to 10 years. If they are not a candidate for tamoxifen, if they have an active DVT or a history of DVT, we would need to do a GnRH analog plus an aromatase inhibitor. So like goserelin, leuprolide in combination with an aromatase inhibitor, because the single agent aromatase inhibitor does not adequately suppress the estradiol. So we need to use that in combination. Kind of similar to our postmenopausal females, we have to add the GnRH analog if we're going to use an aromatase inhibitor. So for advanced disease, we do have all those newer agents that we talked about, the CDK4/6 inhibitors, mTOR inhibitor, the PIK3CA inhibitor. They lack robust data in males, but they are believed to have comparable efficacy and safety. A lot of times males are included in these trials, or their, male breast cancer is not super common. So it's a very small subset of patients. So they might only have like 1 or 2% of the trial population included. Chemo, HER2 targeted immunotherapy and PARP inhibitors, again, also have similar recommendations as in women. So it's fairly the same, just those endocrine therapy options. Usually we're doing tamoxifen upfront if we can. Okay, next knowledge check. So SR is a 35-year-old female with newly diagnosed stage 4 metastatic HR positive, HER2 negative breast cancer. Her past medical history includes irritable bowel syndrome and hyperlipidemia. What would be the most appropriate first-line treatment recommendation? Yes, correct. So because she is stage 4 metastatic, HR positive, HER2 negative, we would do an aromatase inhibitor with a CDK4/6 inhibitor. And I didn't give you if she was pre or postmenopausal, but she is 35, so likely premenopausal. You would want to add ovarian suppression on as well if we're going to do an aromatase inhibitor. Is there anything, so with the CDK4/6 inhibitors, is there anything with her past medical history of an agent that you may want to avoid of the CDK4/6 inhibitors? Yeah, abemaciclib, yeah. So because of that diarrhea risk in like 90% of patients with abemaciclib, probably would want to avoid that and choose ribociclib. Palbociclib would be an option as well, but with the overall survival data for ribo and abema, I would probably choose ribociclib. The other things that you would want to know if you were to choose ribociclib is what is her QTC, so getting a baseline EKG, and then also looking at her current medication list as well. Okay, now they kind of transitioned from treatment to supportive care. So growth factors, this promotes neutrophil recovery between chemotherapy cycles and allows for safer administration of our dose-dense regimen. So that dose-dense EC, we're always giving growth factor with that because their counts will drop. The main benefits of giving growth factors with these regimens is reduction in the incidence, duration, and severity of neutropenic fever. Therefore, we're having less frequent hospitalizations, reducing infection-related mortality, and maintaining their chemotherapy on schedule if they're receiving growth factors. Pegfilgrastim and their biosimilars should be administered once each cycle, at least 24 hours after they receive chemotherapy. So it's recommended for regimens with a higher risk of neutropenic fever of greater than 20%. And it can be considered for those if they have a risk of 10 to 20% and the patient has additional risk factors for neutropenia. So supportive care for bone health, up to 80% of breast cancer patients do experience bone loss. So we should consider bisphosphonate, zoledronic acid, or denosumab for postmenopausal, whether that's natural or we're inducing that for patients that are receiving endocrine therapy. This prevents bone recurrence, bone fractures, and then also improves overall survival in women over 40 years of age. We should also be making sure that patients are taking calcium and vitamin D supplementation to help strengthen their bones if they're on an aromatase inhibitor. If they're on an aromatase inhibitor, then they'll be getting a DEXA scan or a bone scan every 2 years to make sure that there's no significant loss in their bone strength. A little bit different in terms of bone modifying agents for bone meds versus bone health and kind of just helping make sure that their bones don't become too weak. So metastatic disease in the bone can lead to fractures and it can potentially lead to spinal cord compression. So agents that we have to treat bone mets include zoledronic acid, 4 milligrams IV every 4 weeks. Denosumab, which is sub-Q, is 120 milligrams every 4 weeks. And then you can also consider pomegranate 90 milligrams IV every 4 weeks as well. Side effects for this, osteonecrosis of the jaw. So we typically have patients get a dental evaluation before they start on these agents, if possible, to make sure they don't need any dental work, make sure that, there's no issues with their teeth at baseline. Can also cause hypocalcemia, and then flu-like symptoms are pretty common like the first few days after they either receive their infusion or receive the denosumab injection. Another piece of supportive care is cryotherapy. As you can see, they're getting cryotherapy. You can get it in a couple different places, scalp or hands and feet, and this is to decrease circulation to select tissues, therefore less chemotherapy exposure and less toxicity. So for the scalp, this is used to prevent alopecia or hair loss associated with a lot of our chemotherapy agents. If they are receiving an anthracycline, it might be less effective if they do cryotherapy, but a lot of patients usually will opt to do this on their scalp to try and prevent hair loss. For hands and feet can also be used in those areas if they're receiving a taxane, and this can help prevent neuropathy.
Is this cryotherapy something relatively new or?
No, it's been around for quite a while. There's a lot of different brands. We typically use Paxman. It's just the scalp cooling, and then they can cool their hands and feet as well. But the unfortunate thing is that it's not usually covered by insurance. So they have to pay out of pocket for it, and it's not cheap. So it kind of depends on, what their financial situation is. Can we get them potential assistance to help cover it? But a lot of times insurances won't pay for this. So that's why some patients choose not to do cryotherapy. And they also have to be in the infusion chair longer because they have to get it hooked up before and then after as well. So it typically will lengthen their appointment by 60 to 90 minutes. So there's a lot of different considerations that go into if a patient wants to do it or not. And they might still lose their hair despite doing it. So it's not if they do this, then they're not going to lose any of their hair. It might just prevent them from losing all of their hair, but it's not 100% guaranteed that they won't have hair loss. So for cardiotoxicity, as we talked about, anthracyclines can induce cardiotoxicity. It may take years or decades to manifest. You might see it, more immediate short term, but it can also come on after patients have completed chemotherapy. Risk varies depending on the type of anthracycline that they got, as well as the cumulative dose that they received. Some risk factors for cardiotoxicity include older age. So if they're greater than 65 years old, if they have a past medical history of hypertension, dyslipidemia, diabetes, if they have any history of cardiovascular comorbidities themselves, or if they have a family history of cardiomyopathy. For anthracyclines, it's recommended to monitor an echo at baseline. For HER2 targeted therapy, so the trastuzumab and pertuzumab, this is usually reversible if they do have cardiotoxicity. It's not related to the dose compared to the anthracyclines. And for monitoring, we should be doing an echo every 3 months during treatment. So that's built in to their plan when they are receiving HER2 targeted therapy. For the anthracyclines, it's just at baseline, and certainly if they start to have any symptoms of heart failure, then we might do another echo to make sure. For fertility, we can use the GnRH agonist prior to and during chemotherapy to protect against ovarian failure and early menopause. So if patients, are younger in age, still would like to have a family, we can give them a GnRH agonist prior to and during chemotherapy to help protect their ovaries and kind of preserve their ovarian function. With goserelin, the probability of pregnancy increased from 11% to 21% in patients with HR-negative early-stage breast cancer. Results are more conflicting in HR-positive disease. So these patients, if they, really want to have a family, they might do embryo or for cryopreservation as well. So it really just depends on what the patient's wishes are and what they, desire in terms of family planning. So for hot flashes, I know we talked about this in the hormonal agents lecture. It does occur in a majority of breast cancer patients. Adverse effects of our endocrine therapy, including the tamoxifen and aromatase inhibitors. Treatment options include antidepressants, so SSRIs and SNRIs, oxybutynin, gabapentin, pregabalin, and clonidine. So in summary, breast cancer is the most common cancer type in women and the second leading cause of cancer deaths. Treatment of invasive breast cancer is based on surgical resectability, with adjuvant therapy being based on the HR and HER2 status. In these patients that have early stage disease, goal is cure, and genetic testing predicts which patients benefit from adjuvant chemotherapy. This is that Oncotype DX that we talked about. If they are diagnosed with metastatic breast cancer, focus is on palliation, improving their quality of life, and trying to limit toxicity as much as possible. And supportive care is a major component for patients with breast cancer, whether it's early stage or metastatic. Supportive care is really important. That is everything that I have. What questions do you guys have? Anything you want me to go back over? I know it's a lot. Breast cancer is a really big topic, and there's a lot of subtypes. So happy to go over anything again if anything is confusing or you're not sure. Yeah.
Why is it called like triple negative? If we're like looking at HR and HER2, is it like you're looking at any like other markers or?
No, it's just because the HR and HER2 are negative, it's just called triple negative. Although technically, I guess because it's HR is ER and PR, so estrogen, progesterone, and then you have
Oh,
HER2, that's where the triple comes from. But if you think of it like HER2 negative and HR negative, then that's true. But if you break down the HER2, the HR, the ER and PR, that's where the triple negative comes from.
Thank you.
Yeah, of course.